Good morning, good afternoon, and good evening to everyone who's tuned in today around the world. My name is Payal Shah, and I'm the Director of Research, Legal, and Advocacy at Physicians for Human Rights. Thank you to our participants for joining us today for this important conversation. I want to express my deep gratitude on behalf of all of us at Physicians for Human Rights, Med Students for Choice, Physicians for Reproductive Health, and PHR Student Advisory Board to our esteemed panel and our moderator for sharing their expertise with us today. It's my privilege to be here to introduce this discussion today on the day that PHR releases a new research brief entitled Cascading Harms: How Abortion Bans Lead to Discriminatory Care Across Medical Specialties. Since the U.S. Supreme Court ruled to overturn the federal constitutional right to abortion in Dobbs v. Jackson in June 2022, 28 states have enacted or enforced legislation banning or curtailing access to abortion care. Most of this legislation includes criminal and civil penalties on healthcare providers who provide abortion care. Physicians for Human Rights, PHR, and our partners have conducted research with healthcare providers in Oklahoma, Idaho, Louisiana, and Florida to document the multiple ways that state abortion bans have harmed the health of pregnant patients. This past research has shown that abortion bans have caused delays and denials of reproductive health care, including abortion care and miscarriage management. It's disrupted the patient-clinician relationship, impaired clinicians' ability to comply with their ethical obligations and medical standards of care, and overall have had a severe chilling effect on abortion provision, endangering patients' health and survival. In our prior interviews, providers repeatedly emphasized the cascading impact of abortion bans on other forms of care and the need for peer clinicians from multiple specialties to work together to address restrictions that impede quality of healthcare and ultimately may lead to punishment and penalties against healthcare providers. With these challenges in mind, and with the Trump administration's growing assault on science, medicine, and evidence-based care, in our new research, PHR examined the ongoing impact of current restrictive abortion laws and how attacks on medicine and science, including efforts to curtail access to mifepristone and misoprostol, impacts care provided to reproductive age women as well as pregnant patients by reproductive and non-reproductive medical specialists. This brief makes clear what we've heard from many advocates working to defend access to abortion, that there is a critical role for clinicians across specialties to join hands to raise awareness of the dangerous precedent set by criminalization of reproductive health care and what the cascading impacts are on medical care as a whole. Against this backdrop, it's my pleasure to welcome you all to this expert panel discussion, which will be moderated by Alice Miranda Ollstein, a senior healthcare reporter for Politico with a focus on sexual and reproductive health. She is the author of a forthcoming book on the broader healthcare impacts of post-Roe abortion restrictions, set to be published by the New Press in 2026. Without further ado, I'll turn it over to Alice to kick off our conversation.
Thank you so much. So a little housekeeping to start. We're going to have a great discussion with our expert panelists, and then I'm going to ask a few questions, and then we're going to go to a few questions that were pre-submitted by some of you, and then we're going to go to questions that you ask during this very conversation, and you can do that using the Q&A button at any time during the webinar, and we'll try to get to as many as possible. Also want to note that, all our panelists have very impressive titles and credentials, but for the purposes of having a nice conversation, we are going to refer to each other by our first names, and everybody has already given permission for that, so just wanted to let you know. I know some people can, prize their doctor title, so just know that we've already discussed this. So the link to the paper that we are going to be discussing is in the chat right now, so people can refer to it as we talk. But let's meet our great panel to hear about this new report about the impact on the broader healthcare system and patients and providers. So, we invited these folks here today because health providers are really on the front lines right now of these trends that we're going to be discussing. They are seeing firsthand how abortion restrictions are impacting reproductive health care and health care that's completely unrelated to pregnancy. And so we have healthcare providers We have researchers, we have people working in different specialties and different state policy environments, and they can share what they're seeing on the ground and what they are hearing as a result of this important research. So I would love to welcome Dr. Nicole Freehill, who is an obstetrician gynecologist in New Orleans, Louisiana. And I would like to welcome Katie Hauschildt, who is an assistant professor in the Division of Pulmonary, Allergy, and Critical Care Medicine at Oregon Health and Science University, and Michele Heisler, Dr. Michele Heisler, the medical director for Physicians for Human Rights and a professor of internal medicine and public health at the University of Michigan. So we are going to start with Michele for an overview, a brief overview of, I know there's a lot in here, but we would love a brief overview of the findings of this new investigation. And I'm curious, having read over the past couple years, reports Physicians for Human Rights has put out about the impact of Dobbs on healthcare. There have been a lot of state-specific reports, so I would love to sort of hear how this builds on previous findings.
Yes, yes. Thank you so much, and really excited to be here and to have such a big virtual audience. So it's a real delight to be here. As Payal said, we did interview 33 physicians, 32 physicians, and one medical expert from reproductive and non-reproductive health specialties in 20 states. And we looked at 3 different policy environments, states with abortion bans before 12 weeks, states with abortion bans after 12 weeks, and states with abortion protections. We spoke with physicians that did provide reproductive care. We wanted to continue to understand the continuing and changing impacts of abortion bans on reproductive health care, now 3 years post-Dobbs. But we also interviewed physicians from a range of other medical specialties. And we focused on those like rheumatology, dermatology, pulmonology, critical care, oncology, hematology, neurology, and cardiology, as these are specialties that regularly prescribe teratogenic medications, treat patients with health complications that are for which pregnancy is really not recommended. It can be very dangerous, and patients who develop medical conditions such as cancer while they're pregnant, for which which immediate treatment would necessitate abortion care. Overall, we found strikingly that these restrictions have hindered the ability of providers in multiple diverse medical fields to follow evidence-based practices and standards of care. And I want to give you just a couple of our key findings. So some of our key findings were: one, we did find delays and denials in abortion care for patients who experience serious complications from either acute or chronic medical conditions during pregnancy. And let me give you just a couple of examples from our interviews. Again, I hope you read the report. We have multiple quotes and examples that our interviewees gave us. But just a couple of examples are pulmonologists, critical care physicians in abortion states described having to care for pregnant patients with conditions such as pulmonary hypertension or severe congenital heart conditions, who were not provided the option of termination when their conditions worsened with pregnancy. Others who we interviewed who were in a border state, a state that did protect the right to abortion, but they were receiving transfers from a neighboring abortion ban state. And they talked about receiving patients who were critically ill. And then they were, when it was clear that this was so serious, they were sent from the other state for abortion care at their healthcare facility. And it's interesting that we talk about cascading effects, and one of them is actually increased fear in states that protect abortion. One pulmonologist noted that even he sometimes felt worry. He said, obviously, when they're transferred to our state's laws governing, but questions about whether those states will adopt Texas-like sort of vindictive components remain open. As another another interview concluded, and again, we have many examples from pulmonary and critical care, and Katie will provide more as she's done in-depth interviews with pulmonologists and critical care physicians. One concluded you have multiple pathways through which pulmonary and critical care doctors who don't think that abortion bans are going to affect them are being affected, and they're being affected in ways that are really hard for us to measure. A cardiologist in an abortion ban state described now having to counsel her patients with conditions such as pulmonary hypertension, severe cardiomyopathies, that if they chose to try to be pregnant or their contraception failed, if they then became critically ill, they would, in her words, have limited options for abortion in the state. Another key finding, we found delays and denials of abortion care to enable pregnant patients to receive immediate treatment for a new condition diagnosed during pregnancy. Just one example, one oncologist in a state with an abortion ban, she said, in the case of, say, acute AML, myelogenous leukemia, that would be considered an immediate life-threatening condition. That would probably be one of the cancer diagnoses that would fly in her state and others that have outlawed abortion for everything except immediate risk to the mother. But because if they had breast cancer, I, as an oncologist, cannot prove that a woman will live only if they get treatment now and die by postponing it 6 months or beyond the first trimester in some cases. And so many oncologists are therefore afraid to even discuss the potential benefit to the mother of getting an abortion. In my hospital, physicians are afraid to even offer abortion as an option. Another oncologist in an abortion state recounted referring patients to other states, but she even in doing that, she felt worried that she would face legal repercussions for helping them leave the state. She described her anguish about the hardships this imposed on patients. She said, and so that person would have to get counseled and go out of state, which is often very difficult, as you know, for low income and other people who have a lot of barriers to going out of state. And they have to deal with all these while they have metastatic cancer. So again, I have other examples. The other thing that I will say is that something I think has been less looked at is changes in prescribing teratogenic medications to reproductive age patients. Again, due to a fear that patients might become pregnant and be unable to access abortion care. So again, I think a lot of clinicians are on this, and I think you all know that for women of reproductive age who suffer from multiple chronic conditions, sickle cell anemia, autoimmune or seizure disorders, MS, rheumatoid, psoriatic, or other inflammatory arthritis, often the most effective treatments to control progression of their disease are teratogenic medications, in some cases severely teratogenic, that cause or increase the risk of severe harms to a developing fetus or embryo and to the health of the pregnant patient. So I think, again, you all know it is, of course, the standard of care that you discuss with reproductive age women, that they must stop these medications. If they seek to become pregnant, they must, if they're engaged, sexually active in a way they could become pregnant, they must preferably take long-acting contraception methods. But even so, before Dobbs, the standard of care would always be, should pregnancies occur, which they always do, you conduct additional testing, you talk to maternal fetal medicine, and then engage in shared decision-making about whether to continue or terminate the pregnancy. And again, it's always the patient who has that decision. As one neurologist emphasized, in such a situation, it would not be standard of care if we failed to discuss options, including abortion. Another specialist said it's a very individualized decision, but before it would be completely up to the patient, not the state. So in our interviews, physicians described now that, multiple cases that some physicians now in their fields are, instead of risking prescribing more effective teratogenic medications are instead prescribing less effective medications that would be safe in case of pregnancy. One neurologist expressed concern that because of this, reproductive age women were not being offered as effective medication as men. Similarly, a dermatologist at an abortion ban stated, I know a lot of dermatologists here now who don't prescribe Accutane, a very effective but highly teratogenic medication used for severe cystic acne to reproductive age women because of the potential risk of needing an abortion that it carries. I am seeing a lot of these patients who have been turned away. These additional restrictions surrounding reproductive health care definitely makes Accutane harder and harder to access. So what we saw were two resulting forms of discriminatory care. In the first, getting less effective medications, and also in the second, that I think we all know that there are patients that we deem less reliable, and sometimes that's influenced by our own biases. And so physicians described not offering them more effective medications. Again, we found other important findings, the difficulty with pharmacies not dispensing medications associated with pregnancy termination, and other examples. But I'll stop here. But I wanted to at least give you a taste of some of the actual stories that we're hearing in our interviews.
Mm. Thank you so much for that overview. A lot to dig into. And I think, we're going to hear from a few of the other panelists first who are coming at this from different perspectives. So I wanted to ask Katie, since you specialize in the experiences of pulmonologists and critical care doctors who are working in states with abortion bans and, how these laws are impacting their work. These are not OB-GYNs. These are, folks who, don't normally, engage in this space, but they're being impacted in new ways. And so wanted to hear how research you've done, which we can share in the chat, compares with the findings we're discussing today.
Yeah, thanks so much. I'm happy to be here today. So Michele really, covered a lot of the big bases here, that, women are becoming critically ill because there's confusion about whether or not they are sort of sick enough to obtain an abortion under their state's laws, and also these challenges in terms of prescribing teratogenic medications. And one of the things that really was underscored in the research that my team did was how much, medicine is really it's a team, it's a team process. There are lots of physicians involved, there are nurses involved, there are respiratory therapists involved, there are lots of people who are involved in providing care. And so it's not just whether or not, your local obstetric and gynecologist knows and understands the law and has had a chance to consult a lawyer. It is the entire medical team who is feeling that fear and anxiety and not really knowing what the law allows. One of the things that we heard was we heard from a physician who said his patients were having a hard time getting their prescriptions for methotrexate filled. Methotrexate is not commonly used in abortion, but it can be used for termination and under certain circumstances, but it's used to treat a lot of other conditions. And he was getting calls from his patients saying, the pharmacist won't fill this. Can you call them? Can you help them get this medication? So, you think about who is involved in providing care, who is knowing the law, who is understanding the law, when frankly, these laws are not clear. And the risks to patients are going to just continue to kind of seep throughout the system. In another instance, an individual described a case where a woman had an ectopic pregnancy, and there was sort of a discussion in the operating room about whether or not everyone in the room was okay with proceeding, down to sort of the scrub technicians and assistants in the room. These are not people who are used to, poring over the literature or the law in terms of what is medically allowed. They're used to taking, direction from the people who are in charge and expecting that, that the care that they are involved in will be safe and legal. So I think the challenges to the healthcare system are quite complex, and oftentimes we tend to minimize how difficult it is to implement really unclear laws.
Um, Thank you for that. And you're drawing on, some themes we're going to dig into more, changes in prescribing behavior, changes in counseling or lack of counseling, options counseling. These are definitely some themes that keep surfacing over and over. So we'd love to hear a little bit from Nicole about how this is playing out, on the ground between patients and providers in a state with not only a near total abortion ban, but also, additional restrictions on medications layered on top of that. So, as of right now, Louisiana is the only state in the country to designate mifepristone and misoprostol as controlled substances. And it's important to understand how that is playing out in the state, and not just because the effect on millions of people in Louisiana, but also because several other states are considering copycat laws. And so we really want to understand the medical repercussions of this policy. So would love to hear a little from you about what you're seeing.
Absolutely. First, thank you so much for having me. I'm very happy to be here. And definitely, we're seeing multiple impacts, especially with the new law that you mentioned about the mifepristone and misoprostol redesignation as a controlled substance. So, in the same category as very dangerous habit-forming drugs that we need to control. However, these medications do not have that side effect or potential at all. But this is limited access, especially in an outpatient arena. Patients use this medication for miscarriage management. We know its use in abortion care, but here in Louisiana, we still use it on a daily basis for inductions of labor, treating or preventing postpartum hemorrhages, miscarriage management, prepping the cervix for different procedures such as IUD insertions, biopsies inside the uterus, other things, and even infertility treatments that need a procedure are being affected by this new classification. So there are many pharmacies in our area. There's been some research done that is not published yet, but going to be soon, showing how a lot of pharmacies in our area and even in the entire state have stopped carrying misoprostol specifically because that is the most widely used medication for many things. And we are seeing pharmacies have concerns about the legal ramifications. Others are citing the amount of work and documentation and changes to their processes that are needed to dispense these medications now, and that they make pennies on this medication because it is a very inexpensive, cheap, wonderful drug, but they don't make any money on it. So they're not going through the hassle of redoing their system for dispensing it. And, we're also seeing changes in our inpatient access. So there's also research being done, again, not published yet, but basically we had to do a workaround in order to make sure we had this medication available to us for inductions of labor, postpartum hemorrhage, as I said before. And this involved, a large amount of work, specifically in the hospital system where I work. This was a large amount of people from OBGYNs to pharmacists to administration to nursing, etc., that came together to redo the way that we carry, the way that we store, and the way that we access the medication misoprostol when we need it quickly. And I actually love to quote one of my colleagues who likes to say, we had to fix a problem that was not broken. And so all of this time and this manpower could have been used for many more productive endeavors, but we had to fix this problem that didn't need fixing. So I'm hopeful that as we get more research and more numbers and more data to come out, we're going to see, are there other impacts besides the outpatient access and what that's doing for patients who have miscarriages and need the medication for other reasons, but also things like postpartum hemorrhage, complications from hemorrhage that can include very serious permanent injuries and even death. But we just don't have that data quite ready yet.
Mm. Can you quickly say a little more about the workaround? So I've been hearing, a lot of concern because sometimes misoprostol is the best medication to very quickly, intervene when someone's having an obstetric
Mhm.
emergency. And
Mhm.
the new barriers, having to have it in a locked container, potentially in a different room, potentially in a different building in some cases. And so there's worry about doctors being able to access it when they need it. So I'd love to hear a little bit, briefly, a little bit more about that.
Yeah, absolutely. Well, I can only speak to my hospital system. We have a hemorrhage cart that is refrigerated because a lot of the medications that we use other than misoprostol need to be temperature controlled and refrigerated. So we have a hemorrhage cart that has a refrigerator section, but also has other things like misoprostol, a Jada device, which is a balloon that tamponade suction device that you put inside the uterus, other things too, so that we can just bring that hemorrhage cart in from the hallway or have it in the room when we're delivering so that if we need anything, we can just access it right away. Misoprostol is not something that needs to be refrigerated. However, it needed to come off of the hemorrhage cart because there was no good way to change the hemorrhage cart enough to lock it up in the way that was needed when this reclassification happened. So the misoprostol had to be put elsewhere. And in our situation, we put it in the Pyxis, which is the mobile pharmacy dispensing device that is on our labor and delivery. And we kind of changed some of our order sets to make it pre-ordered and easily accessible if we need it for a patient. So that is how we changed things and worked around it, but there was a lot of time going into, can we change the hemorrhage cart? Can we rebuild it? Is there a special locked area we can put in it? How do we make sure that we get this misoprostol quickly and don't have to go through all of the hoops that sometimes you have to if a control medication is kept in the main pharmacy and not like on the labor and delivery. So we had a lot of time figuring that out, but that's our workaround that we came up with.
Thank you for explaining that. I think we want to sort of pivot the conversation a little bit to the policy environment we are living in, which is changing every single day at the state and federal level. But you know, thinking through some, potential developments that we're all tracking that could impact these things we're talking about significantly. So a lot of this is, related to access, mainly to mifepristone. It's a lot harder to restrict access to misoprostol, although Louisiana has managed to do it. But it's harder because it has so many other medical uses for ulcers and all kinds of things. Whereas mifepristone is primarily used, in an abortion context. And so it's a lot more vulnerable to these kinds of restrictions that are being debated right now. And so, things that people are watching for, there's still an ongoing lawsuit in Texas, and many different states are attempting to join that lawsuit related to access to mifepristone and rolling it back at the federal level. There's also the potential for the federal government to revive the Comstock rules, which prohibit the mailing of not just mifepristone and misoprostol potentially, but also, medical instruments that are used in abortions and other medical care. That's something people are watching out for. Obviously, we're seeing a lot of cuts to funding for reproductive health all around the country, clinics closing. And so given all of this going on, curious to hear about, sort of the policy advocacy people are engaging in right now. And so, yeah, wanted to just stick with you for a minute, Nicole, and hear about, how both clinicians and advocates are responding to these issues in Louisiana.
Yes. So there's been multiple ways that we've responded from a physician and institutional standpoint. I'm very happy to report that in my institution, one of my colleagues, Dr. Stacy Holman, actually worked tirelessly to work with our system to be able to have mifepristone available in our hospital system so that we can have access to it to treat miscarriages. And that is the most effective way to treat a miscarriage also is the two method, the mifepristone and misoprostol. So we did this after the Dobbs decision. So that was I think a big win for our hospital and for the patients in our community because we have that option to use the most effective medication management option. I think that one of the things that has come out of this is communication, I think, between physicians and across a lot of people in the medical world has increased significantly. I get calls and emails from doctors and other providers almost weekly asking me to clarify a law or review where patients can still obtain misoprostol for a miscarriage or multiple things. And I think that improved and increased communication is key for situations like this. I think that this will have a larger impact in the future as we continue to do our best to provide the best possible care to our patients and to try to hopefully prevent new laws or reverse some of the laws that are here that are causing problems with access and with treating patients appropriately. Another way that we're kind of advocating is new research. As I mentioned before, there's been multiple studies that are ongoing, some that are completed, some that are still ongoing about what a lot of these laws are doing to our patients and to access and to outcomes. And I think that this information, this data will provide us with the ammunition of scientific evidence and facts that we need to combat the current laws and the new laws that are no doubt going to be proposed in the future. Research is, historically how we drive forward better care and new innovations and come up with our standards of care in medicine. And I think that we will continue to see that with all of these laws. So that's another, win, I think, in a way, even though I hate that we have had to do this, it's definitely something that from a physician standpoint and a researcher standpoint, that's important. I think that as far as an advocacy standpoint, I've seen a lot of physicians become more involved and be more aware of these laws than they ever were before. This treatment of miscarriages and abortion in general, because of the situation that we're in so many states in our country. And I think that this has kind of galvanized many people, a lot of us in medicine, to say basically these laws are causing problems, and we're not going to just sit back and let it happen if we at all can. So wins like mifepristone access in my hospital system, having my research request into the effects of these new laws granted by my institution, increased communication, all of these things are just a few of the wins and positives that have come out of these changes so far. And I'm confident that we'll have more.
Mm-hmm. And on the theme of research potentially leading to policy changes, it's it can be cited in lawsuits, it can get press attention and try to change hearts and minds that way. And sometimes that forces the political leaders to respond. So would love to hear a little from Katie on that front of how you're seeing that playing out right now in your own work.
Yeah, definitely. I mean, sort of echoing Nicole's experience, I've definitely seen a lot more sort of activation of physicians and other clinicians involved in providing care in really sort of having a bit of a political or sort of a policy awakening and feeling, I think obstetrics and gynecology, unfortunately, have been on the front lines of feeling like the care that they provide is politicized for a really long time. But I think, unfortunately, other areas of medicine are starting to see how this is all connected and see how the politicization of medical care is harming their ability to provide care across medicine. One of the things that again, I hesitate to sort of call it a win, but that I think this has given people sort of the permission or the excuse to feel like they can speak from their professional identity about topics that are deemed, political. I think a lot of healthcare providers, regardless of their specialty, really believe that in order to provide, good patient care, they provide care to everyone. They don't need to politically agree with everybody to be that patient's doctor and to provide them with the highest level of care. And so in some ways, sometimes that has depoliticized them and made them feel like they can't speak out on topics that are perceived as political, because then that they're not sort of fulfilling their mission to be apolitical as physicians. And I see that is changing, that they're sort of saying, no, actually, it is my identity as a physician that requires me to speak out, that requires me to advocate for the laws to be changed, that requires me to go to my institution and say, how are we going to keep our patients safe? As Nicole mentioned, I think institutions can really play a big role here. They can play a big role in minimizing or mitigating the harms of these laws. They can play a big role in ensuring that their physicians and their nurses and everyone on the clinical team feels supported and protected in providing the care that patients need. And part of that is having those open communications, saying, here's what we're doing, here's how we're approaching the law, here's our policy, here's our procedure, here's what to do if you have a patient who looks like they might need care, or even if you're just really nervous, because this is one thing that came up, physicians are nervous about doing anything to pregnant patients, unfortunately. We heard an instance where someone, was sort of asked with a critically ill patient, well, what would you do for this patient if they weren't pregnant? And they said, I would do this procedure. And they said, okay, then you should do this procedure. They said, I'm not going to do that procedure. What if she loses the pregnancy? This perception and this fear that they are at risk, in just doing what they think is best for patients, even if it's not directly even providing termination care. That is something that institutions can step in and say, listen, this is what the law is. This is how we're following it. Here are our procedures to keep our patients safe and to keep our providers safe and to keep our clinicians protected, and know that, you are following the law and we have your back. So I think that there's a lot of opportunities there for, obviously, advocacy to change these policies and to get rid of these laws that are really harmful, but also opportunities for institutions to mitigate harm, and for physicians and other clinicians to work together to encourage their institutions to help mitigate harm, to say, this is what we need to do our jobs. Can you help us?
Mm-hmm. That fits with what I've been hearing from a lot of people in the medical world of, they say that in their view, the true and only solution to these problems is to get rid of the abortion restrictions altogether, but understanding that that might not happen soon or ever. They're looking at, within that, how to protect patients and mitigate some harms. But I would love to hear a little bit from Michele about, this report is now out, and how you are hoping to use this directed in an advocacy way. How are you hoping to mobilize, the provider community, and to what end? I know there's, specific policy recommendations in the report directed at different levels, state, federal, providers, advocates. So want to hear a little about what happens now that the report's out.
Yes, thank you. Well, clearly, we hope that you and all our partners will share this report, share it widely with your institutions. Like Nicole and Katie, we still believe that evidence matters. Ultimately, what can we do? We can produce good evidence, rigorous, objective evidence. So I think that's one thing we want to continue to do, is to provide this evidence, and we hope you all will share it. We at Physicians for Human Rights are very much a network of clinicians, across the US, across the world. We are a multidisciplinary network, including reproductive and non-reproductive healthcare providers. So part of what we're doing, as we are doing in other areas, such as the attacks on the right to asylum in the US, is we are seeking to really strengthen our networks, to get information out to our networks, to engage our networks into advocacy opportunities, trainings, webinars like this. I hope all of you on the call who are not yet on PHR's listserv, so that we can get information out to you, updates, opportunities, advocacy, sign-ons. I'm hoping, I don't see the chat, but I hope that if you haven't signed up, you can just take a few minutes now and just sign up so that you can be part of our networking activities. Certainly, this report we saw as very important to continue to remind all of us, I'm an internist, that this impacts all of medicine. These laws, like so much else that is happening, is an attack on medicine, on the integrity of medicine, on our ability to follow our professional obligations to our patients. Quickly, a few other things, because we want to be sure there's opportunities for your questions. This is a call to action, and I just reinforce so much what Katie and Nicole said, is that, we as healthcare providers are in a privileged position. We are, many of us, on the front lines caring for our patients. And as such, we do have an obligation as part of our profession to advocate on behalf of them. So, again, I think my dear friend Lisa Harris, who has really helped us think about how to talk about this, I think she's on this call. We need to speak within our clinical voices. And I think by doing that, we can raise awareness of the harms caused to patients and healthcare systems. We are in a position to share de-identified stories about what our patients are facing, amplify their voices, what they are experiencing. And so I will also say, and I think we're all grappling with, how do you get information out to people who are not already, believing things, or having access to the information we have. If you are on social media, I think we need to be sharing stories on social media and the impacts on our patients. We need to be assisting other clinicians in navigating the abortion bans and restrictions. We need to fight for our right to continue to provide patients with the proper standard of care. In some cases, that may be their right to receive information, to receive referrals and support if they need to go out of their state. And we need to continue to support clinicians and medical students of all specialties to attend trainings on abortion care, other reproductive health care. So I think those are, there's a lot that we can do. I will say specifically that PHR will soon have an advocacy opportunity about access to medication abortion. So again, I hope you'll sign up to our listserv so you can participate in that advocacy opportunity. Finally, I'll say, and again, I think many of the people on this call have so much expertise. We at PHR, one of the things we are doing is collaborating with legal teams to ensure that our evidence, the medical voices, can support legal challenges. So again, there may be other ways that you can leverage your expertise for the critically important strategic litigation that is happening now.
Thank you. And so we're going to go to a couple of the pre-submitted questions. We got a lot of really great ones. But just as a reminder, you can pop more questions as they come up in the Q&A on Zoom. So yeah, we'll sort of throw this out to any of the panelists, but we got a question about care for minors specifically. We know that in states with abortion restrictions, there are often additional restrictions on what can be said to minors, what assistance can be rendered, their ability to travel, et cetera. And then there's, also increased, legal considerations for the provider. And so wondering, what findings folks have to share about that.
I can speak for Louisiana this past year. There was an attempt to pass a law that restricted minors from consenting to any sort of medical care. And I think that was more aimed at trans care. However,
Mm.
you think about all the different things that minors can consent to, including contraception, abortions. I mean, it's a huge list, correct? And so I think that thankfully that did not pass, but there are attacks like that. I think there's going to be more attempts in the future to limit what minors can consent to, what they are allowed to do with or without parental or supervision oversight. So I think that's something that we've seen and we will see.
I've also heard that research on minors' experiences post-obs is additionally challenging with mandatory reporting laws and all kinds of things. And I've heard, some institutional review boards are hesitant to approve studies that focus on minors. And so there's a concern because, minors are already underrepresented in research and, have these vulnerabilities that deserve, attention and scrutiny. But I don't know if anyone wants to speak to that or anything else related to this question before we move on. Okay, well, we have tons of questions, stuff to keep thinking about. So this pre-submitted question sort of combines with one that just came in, which is sort of how clinicians can, translate these findings into tools to better be able to render care themselves. And so, the question we got, was specifically about exceptions to abortion bans. And, we have seen in research and, in reporting that, those exceptions are often very challenging to navigate. But if there are any examples of, people being able to practice up to the limit of the law and sort of advocate for the most care possible.
Yeah, I mean, one of the things that sort of came up in some of our research was again, this going back to like this bit really being sort of an institutional effort, was some institutions have created the equivalent of kind of like a rapid response. So in these situations for patients that are critically ill or approaching becoming critically ill and termination is really the appropriate medical care that they need. They've really operationalized that. They've created a procedure of who to involve, how to get a hold of that person. They've made that person or persons available 24/7. And preceding that, they've come up with an institutional policy, really sort of clarifying where they are on some of the more common types of exceptions or health situations that might come up, but also saying, this is not exhaustive, but that's why we're getting these people involved, and we're making sure anybody in the hospital who has a question can reach out to this team, these experts at any time, and get the answer that they need to provide the care that is required for their patient. So I definitely think that operationalizing exceptions. I know that one of the things we also heard was that sometimes institutions are afraid of operationalizing exceptions because they don't want what becomes operationalized to limit the exceptions that are available, right? You couldn't possibly think, as this research has shown time and time again, of every single situation and where the questions around the law might impact care. And so policies are not designed to say this is what's allowed and anything that's not here is not allowed. They're really meant to kind of fast track some of those things where we know it's going to come up and we know it's going to be a problem, and make sure that physicians can act quickly and their clinicians can act quickly. But making sure that that's not, the policy is not the end. You need to have people who are involved, and they need to be available to every clinician in your institution who treats patients who might become pregnant, which is probably all of them.
Mm-hmm. And I know a lot of states with abortion bans have, have amended them or put out additional guidance because, they're seeing these repercussions and people being denied care. And so, they've either passed laws or put out guidance saying, somebody's a pregnant woman's, death doesn't have to be imminent for an exception to be triggered. You can intervene earlier. Listing more different conditions, having tweaking the language around that. Uh, does anyone want to speak to those changes and whether they've, made a difference in this space?
I feel like these changes are trying to do the right thing and broaden the access and broaden what physicians can consider as far as part of what can fall into an exception. However, a lot of the language is still legal language, and it's still extremely confusing to most physicians because just like lawyers speak legalese, physicians speak medical language. And if the medical terminology is not clear in the laws, I think that it still creates a lot of confusion. And as soon as you look at a list of exceptions, you are immediately going to go, oh, that looks pretty comprehensive. But then the next day, you're going to find something else. Like it's extremely hard to put a border on this is the number of exceptions and these are all the things we see and there's nothing else that's going to fall into this. So I think it needs to, the language also needs to be broad enough to allow for the nuances of things that come up and happen to patients and to fetuses that you just haven't seen before. I've been practicing for 20 years. I still see situations that I'm like, never seen this before. So
I want to add to that though, because again, I think it's not just a question of the confusing language. I mean, again, I think the risk is that you blame physicians. Like, why are they so confused? It's so clear. I mean, I think the exceptions are acting the way they were intended to act, which is to basically chill the provision, prevent the provision of abortion care. And I think when we look at a number of the restrictions, the exceptions, I mean, a lot of the cases that I've heard about in our interviews are actually cases that would not fall within the exceptions. So, if you may not have lethal fetal demise, which is, it has to be a lethal fetal condition, which actually may not be interpreted that will cause death within a week after delivery. We have restrictions that say that it has to be life-threatening or cause irreversible organ harm. Some of the health harms are not necessarily immediately life-threatening. So again, I think we need to think, if we're really thinking about the health of the pregnant patient, if you delay cancer care, can you, as one oncologist said, can you definitely say that patient would die, or the case of someone who had severe kidney failure, and their kidneys continued to get worse, but would it be, so I think we need to recognize that these exceptions were meant to decrease access to abortion care, and they're actually being implemented the way they were intended. And it's not the fault of clinicians who do have to navigate staying within these very narrow and deliberately written so as to make many clinicians feel that a case will not fall within the exception.
Yeah, I've been hearing from, a lot of providers around the country concerns that, if the exception language is written too broadly, then they're left confused. It's too vague. They don't know when to act. But if it's too narrow and prescriptive, like listing specific conditions, then, inevitably something will not be on that list. And it creates the impression that if something isn't on the list, then it doesn't count. And so there's that tension between, having additional detail, but not so much that it's, too prescriptive. So we just have a couple minutes left, and I want to make sure we've gotten several questions in the chat about the impact on medical training, medical school residency. This is something I've reported on. I'm definitely gonna have a whole chapter in my book about it. It's a really big issue. And so, would love to hear a bit from the panelists about that, how abortion restrictions have impacted the kind of training physicians receive. And, one thing to keep in mind that I learned over the course of my book research is that, Texas, for instance, is just like a medical powerhouse that, produces physicians who end up practicing all around the country. And so it's something that everyone needs to be paying attention to and caring about. And it can't be sort of written off as, oh, that's a red state problem, because we really have, a national system of medical training. And there's a high likelihood that no matter where you live, you could have a doctor who was trained in Texas. And so what kind of training that person can access matters. So yeah, I would love to hear a little about that.
Yeah, I can talk a little bit about that. I mean, again, across our research across multiple settings, I think we're seeing a couple of things. One, and I think this is being borne out in larger statistics. And Alice, I'm sure these are statistics that you've noted in your upcoming book. I mean, one, we're going to see that people that do want to receive training in abortion care are going to choose not to go to medical school or do residencies in states with abortion restrictions. We're already seeing this, as we're already seeing an outflux of OB-GYNs and other specialties out of states with abortion bans. So I think we're going to see kind of a segregation that people that are very opposed to access to abortion will choose to go to medical school and do residencies in states with abortion bans. I think too, we'll see I think a frightening decrease in technical skills in states with abortion bans. I mean, you need to know how to do medication abortion, procedural abortion in cases of miscarriage management, and really frighteningly, already, and I think Nicole can talk to this, we talked to OB-GYNs that say, I'm one of the few OB-GYNs remaining in this state that knows how to do a dilation and evacuation. A D&E, which is really, it's not in a true, I mean, if you have someone who absolutely is in a life-threatening situation from, PPROM or something else, that's, in the second, third trimester, you can, obviously, see if you could deliver or, but the D&E is really the only non-invasive, not nearly as invasive as some people are arguing you should do a cesarean section. And we did see that in Louisiana, that people that had non-viable fetuses were being subjected to a very invasive procedure, surgery, abdominal surgery that would have future impacts on ability to have a vaginal delivery. So again, I think that's an important question we all have to deal with, that we're hearing open calls that, well, why would you even know how to do a D&E when you can just do cesarean section? I mean, I think we really need to think about the implications of that for the health of pregnant patients. So I think those are some of the consequences. It is true that many institutions, and again, Nicole can talk to this, many academic medical centers are working out arrangements with other states that they can have an away rotation. They have, say, again, I don't know, some of the institutions in Louisiana say might have an arrangement with California. I will say, coming from someone in Michigan, is that not, Michigan, can't handle all the residents or medical students, so again, I think that there's going to be a limit to how many how many students and residents that institutions in non-abortion states. I mean, we have an obligation to train our own medical students and residents before an obligation to train those from other states.
Yeah, Michelle, I was just going to add to that, which is that, one of the things that has come up in some of the research that my colleagues has done is that this is affecting the decisions of where to train and where to practice for physicians across medicine, not just, obstetrics and gynecology. Because if you think about it, clinicians are young adults. They are often in their 20s and 30s. They are considering starting families of their own, and they want to be in a place where they feel safe starting their own families, and they feel like they can access care as patients, not just provide care as physicians. And so I think the impacts of these restrictions are sort of spreading beyond obstetrics and gynecology. They're going to be affecting the training of physicians in lots of different specialties. And ultimately, when we see that sort of exodus of obstetrics and gynecology, one of the physicians that I spoke with talked about how because of the exit of an obstetrics and gynecology folks, one of the labor and delivery units near not at his institution, but at another institution closed. And so then their institution absorbed all of those patients, all of those pregnant patients, all of those labor and delivery patients. And so now they were seeing more critically ill patients because this entire unit closed. So these effects, when we think about training, it's really everywhere in medicine that we need to think about where are trainees going, where are our clinicians going, and how are we making sure that people have access to care, all of it.
Yeah, I'll
Absolutely.
just say that I think we have hit ahead a very sensitive topic, and I could speak on this for literally another hour, which I'm not going to, but I think we have another webinar in our future to discuss this topic specifically, because it is, as both Michele and Katie have mentioned, it is huge, wide-reaching implications that we're already seeing in OBGYN and other specialties for sure. So yeah.
Yeah, and I'll just throw out that those away rotations, so people traveling from a state with a ban to a state with abortion protections to get abortion training, that's still required for everyone to become a board certified OB-GYN, but it is not required for other specialties. And so, people in family medicine and other specialties who used to have access to that training have now lost it. And even for the folks for whom it's required, some people just can't make that happen. They have, an elderly parent to take care of. They can't just go to another state for several weeks. That's just one of many reasons I've been hearing about the challenges. So definitely way more to say about that. But we are at time, and so I wanted to turn it back to Michele to wrap this all up and send us off.
Well, again, thank you all so much for attending. And I guess I will conclude. I hope you will read the report. I hope you will share your experiences. And please, we at PHR, and again, I also, for those of you who are medical students, there's medical students for choice. Please learn more about all of us and our partner organizations. And I hope very much you will join our network of clinicians in the U.S. And I appreciate one of the comments that we're called physicians for human rights, but we really should be called clinicians for human rights, because we have many nurses, nurse practitioners, as well as midwives. We have psychologists. We have public health officials. So please join our network. We are a true network of health care workers, providers, and not just physicians.